Well, good morning, everyone, and welcome to Quinnipiac University. My name is Dr. Edward O'Connor. I'm the Dean of the School of Health Sciences, and I wanted to welcome you to our panel today on healthcare reform. How will healthcare reform affect you, the employer? And I do welcome you to Quinnipiac University in our North Haven campus. A couple housekeeping items I just want to take care of. Please turn off your cell phones if you wouldn't mind. And bathrooms, if you need to get up and go out, there's one to the left, a single bathroom, a left and a left, and one, a right and a right. We'll take you to the next set of bathrooms, okay? Fire alarms, if fire alarm did happen to go off, fire exits out the back here, and either to the right or to the left. I do want to thank our sponsors today, the National Institute for Community Health Education here at Quinnipiac University, in which I serve as the executive director. And also like to thank our friends from the Greater New Haven Chamber of Commerce, the Healthcare Council, who are supporting this event as well. Next, I just want to introduce to you our panel, and we'll talk about different aspects of this. Dr. Phillip Brewer is the medical director for Quinnipiac University. Lynn Price, next to him, is the associate professor and chair of nursing. Cynthia Lord is associate professor and program director for our physician assistant program and a past president of the Academy of Physician Assistants. Mattie is an associate professor of management and teaches healthcare management in our business school. And at the end of the panel is Professor John Thomas, professor of law, who teaches healthcare law. So what I thought, each of those will get up and talk a few minutes about the different aspects of the healthcare reform bill and how it affects on employers. And what I wanted to do is talk about, we had a pretty busy day yesterday. So hopefully many of you got out a chance to vote and have your voice heard. I often tell my students that voting is your ticket into the conversation. So just quickly, people were worried about what would happen if the Republicans took over the House and the Senate. Would they be able to repeal the Health Care Act? And so let's take a quick look at the election results. These aren't final. As probably many of you know, there are a couple things, races still unfinished, and we'll have some issues that may linger for a while. But as of pre-election, we see on the left, the Democrats held 59 seats in the House, and 41 to the Republicans, with 37 of them up for re-election. So as of this morning, the Republicans made a huge advance in seats, but as you can see, the Democrats still hold the majority. And that 51st vote is important. Gives them the majority vote. And there are two seats still not clear, but CNN anyway projects, and these results are from CNN.com, projects that it will not swing. It can't. The 51 seats are set. On the House side, a little bit different. As of pre-election, okay, out of the 435 seats, 256 were held by the Democrats, 179 for the Republicans. A big shift here, okay? A sway of balance of power. The Republicans now hold 239, and CNN's projecting they'll end up with 243 seats to 189 total when it's all said and done. Okay, and so for those of you who like the red-blue maps here, you can see this is what the results look like for the House. And so there's a big change, lots of red across the states here now, and a big swing in power. So what does this mean for healthcare reform, though? So under people's best or worst nightmares, whichever way you have your bent, if the Republicans took both the Senate and the House, people were thinking that they could repeal the Healthcare Reform Act. The reality was, even under the best of circumstances for the Republicans, they would have a very difficult to virtually impossible time to repeal the act. They wouldn't have the votes to overwhelm a Democratic filibuster, much less overturn a presidential veto. And just quite frankly, I don't think much about the Healthcare Reform Act is not a philosophical battle. Most people understand and agree with the need to provide access to health care for everyone, and the question is basically how are we going to do it and how are we going to pay for it. There are many provisions in the Health Care Act that people are looking forward to. For you students out there, being able to have your parents be able to keep you on your health care, on their health policy till you're 26, which we can already do in Connecticut, is a plus. This doesn't happen nationwide. Dealing with pre-existing conditions, and there are many other parts of the bill that are important. So I'm going to turn this over in just a minute, as a recap of the elections in the state. As you probably know, the Democrats won all 5 seats in the House, or kept them. Richard Blumenthal won in the Senate, and they were predicting victory pretty early. I thought some people were thinking it might be a little closer race than it was, but it wasn't. And obviously the big one that's still left open and we don't know the result of is the Foley-Malloy gubernatorial race. And if you've been following the news, which it's in 1% still, and if you've been following news, Bridgeport extended their voting. So my sense is, and maybe Professor Thomas will speak to this, that whatever happens, someone's going to contest those votes, and this could drag on for a while. So I'm not sure we're going to have a governor for the state of Connecticut for a while. So there'll be more to come, I'm sure. So at this point, I want to turn this over to our first speaker, Dr. Phil Brewer, okay, who will give an overview and highlights in what is missing in this bill and how it affects the employers. All right, Phil? There you go.
Do I have something to control?
You can do it from there?
I don't know, we're sitting down or, since we have 5, yeah, I'll stand up. Thank you, Ed. So I originally had 31 slides to do in 5 minutes, and I obviously pared that down and took advantage of the results of yesterday's election to, I want to get this on the first slide.
Go back then.
Yeah, okay. Take advantage of the elections to revise the emphasis a little bit. The Congress did pass health care reform, and to much opposition. And of course, last night we saw what happened, and we can expect changes, which I'll get to at the last slide. I want to go through very quickly the highlights of the provisions of the Patient Protection and Affordable Care Act, PPACA, and then at the end kind of go back and talk about the things that are likely to change with the new political scene. One of the major issues is it demands an individual mandate to be insured. This is now in the courts. The Supreme Court will certainly decide whether the federal government can require people to do this, and there's a consensus that they will not declare it unconstitutional, but I think it's hard to predict with any degree of certitude. For employers, and that's the emphasis today, employers who have more than 50 full-time employees will have a $2,000 to $3,000 penalty per non-insured employee if they do not offer a health plan. There will be a voucher system for people who are up to 400% of the poverty level, in which they will be subsidized for health care premiums such that what the employee has to pay out of pocket doesn't exceed 9.8% of their salary. There will be mandatory auto-enrollment if you work for a company that has more than 200 employees. And there will be expansion of about 130% to 130% of people who are eligible for Medicaid and CHIP. The federal government kicks in to subsidize this early on, but that phases down, and so more of that burden falls on the states. And this is one of the reasons why a lot of the states have filed suit against the federal government to block this. There will be premium subsidies on a sliding scale for people who are between 133 to 400% of the poverty level. There will be tax credits for small businesses to help them provide health care benefits for their employees. For people who are less than 65 years old and no longer employed and no longer receiving health care through their employer, there will be a temporary reinsurance plan to allow them to get affordable insurance while during the years that they're waiting to become eligible for Medicare, and they can start getting Medicare. There will be some new taxes. There will be some new taxes. There will be a penalty for non-insured people, which is going to be imposed by the IRS, which will require new mechanisms at the IRS to determine, to validate that somebody does or doesn't have insurance. There will be an excise tax on what they call platinum plans, which are plans for which a family premium is more than $27,500 a year. There will be increased fees and taxes on fees for pharmaceutical manufacturers and commercial health insurance companies. There will be an excise tax on medical devices of 2.3%. So a hospital, for instance, that's contemplating capital expenditures to buy a new MRI, for instance, will pay an additional excise tax on that. One of the backbones of the plan is to create exchanges which will be run by private insurers, but which will provide low-cost insurance to individuals who aren't covered by any of the other provisions. It creates 4 tiers of benefits, 60% of expenses. So if you have a bill for $100, it pays $60. And that's called bronze, silver, gold, platinum, as well as catastrophic care. How am I doing?
Keep going.
Okay. It does allow insurers to create rating rules. So if you're a tobacco user, they can charge you 1.5 times what they charge a non-tobacco user. They can charge you more if you're old, up to 3 times the rates compared to if you're young. It requires plans to create adequate provider networks, to have outreach so that they're not cherry picking, but they have to prove that they're marketing their plans to the general population. And it requires a lot more openness as far as what their expenditures are on health care. For private insurers, it prohibits rescission, which is this infamous practice of once people have gotten sick and run up very large medical bills, going back to their original application and finding reasons to say, oh, in fact, you're not insured and we're not going to pay the bill. That's prohibited. It provides for dependents up to 26, and it prohibits exclusion because of pre-existing conditions. There are some cost containment provisions, but they mostly have to do with trying to cost contain as opposed to an actual knife that slices out expenditures. And there are also improvement measures which will, the mainstay of which is the Patient-Centered Outcomes Research Institute. There's a small portion for malpractice reform. There is money for independence at home to try to keep people out of nursing homes and more expensive forms of care. And then finally on this slide, increased reimbursement for primary care. Primary care providers are reimbursed at much lower rates than actually what it costs them to practice in some cases. and that's going to be corrected. One of the big things is the idea that if you get people to be healthier through prevention, you can save money. That actually hasn't been proved to a lot of people's satisfaction, but that's one of the fundamental ideas in this bill, and so it creates various measures to increase prevention. For long-term care, which is going to be a bigger and bigger issue as the population ages and we have fewer people at home to help take care of this aging population, it provides for new ways of dealing with that. It phases out the donut hole in Medicare, has workforce issues to try to increase the number of people going into medical training and allied health training. It funds community health centers and okay. And that's all I have time for the overview. What will change is that Joe Barton will be the chair of Commerce and Energy, and he has declared that he's going to have Kathleen Sebelius coming up to the Hill on a weekly basis or daily basis. He's basically going to interfere with her ability to do her day-to-day job as the Secretary of HHS. It's also going to defund everything. Going back to the things that we've just seen briefly, a lot of them require additional funding, additional appropriations bills. And John Boehner, who's now going to be the Speaker of the House, has said very explicitly multiple times he will not pass any appropriations bills to support the Health Care Reform Act. So all the money that's needed to set up exchanges will not happen. So in a lot of states there won't be exchanges, and since that's a big backbone of this system, it's actually going to look very different in reality than what it was envisioned to be in theory. So with that, I will pass on to the next speaker.
My name is Lynn Price, as you may remember, and I'm chair of the nursing department, and my job is to sum up in 5 minutes 3 of the major pieces of the bill. One is the individual mandate, one is the employer mandate, and one is how we're going to implement this, which will be very different, as Phil just mentioned. The individual mandate I'm not going to spend a lot of time on. This slide indicates to me that really this is not about health reform, this is health insurance reform, and the way it's delivered and what its provisions are around what any particular policy might say. The gist of why this was created is, I think, captured by this cartoon where a patient finds out from his provider that, uh-oh, your coverage doesn't seem to include illness. And because there have been a lot of problems with individual policies, rescission, as Phil has mentioned, and pre-existing conditions, finding out that for cancer care or other kinds of very serious chronic diseases, all of a sudden you've run into a lifetime limit and you no longer have coverage. There's lots of different problems with current insurance policies many times. So that's what this bill was designed to address in large part. Why you're here today, no doubt, is to find out more about the employer mandates. I have left a handout for you, excuse me, which is a summary of potential penalties for employers that was compiled by the Congressional Research Service, and in my mind is one of the most neutral documents that I was able to find, as well as one of the most accessible. I looked for a picture of this legislation. It is over 1,200 pages long, so it's very difficult to summarize all the different ins and outs, as Phil mentioned, and as you saw, just the minimal amount of detail on his slides. But the gist for employers is that if you have 50 or more employees, the bill applies to you. Now, the question is how you count that up. That's 50 or more full-time employees, full-time meaning that you work more than 30 hours a week. The caveat here is that there's a way that you can count part-time, non-seasonal employees. and you basically add them up in full-time equivalents, and they can run you over. So if you're a small firm that's hovers around maybe 40 employees, but you have a number of part-time employees, you could find yourself covered by this, even though technically you don't have 50 full-time employees working 30 hours or more. The handout that I gave you does summarize that for you. The other handout I left for you is an implementation timeline, which I'll get to in a minute. If you are covered or mandated by this bill as an employer to offer coverage, the coverage must be at least the essential minimum is the term of art that is used here, which equals the individual mandate. Basically what this means is employer-sponsored plans, what exists now under Medicaid coverage, under the Children's Insurance Program, the CHIP program, et cetera, under TRICARE if you're a military person, under veterans insurance, and so on. So it has to offer at least a basic amount. Exactly what the benefits will be are supposed to be determined by Human Health and Services, and as we just heard, that might not happen because the head of that agency is be running up to Capitol Hill on a regular basis, apparently. If you are an employer, one of the important things to know is, and one of the reasons I think the business community is concerned about this, is because you have to report your compliance, and you do that through the taxation mechanism. In other words, the IRS is the one who's really monitoring this. All of this is set up very much on what happened in Massachusetts. It's very similar to the model that our colleagues to the north have already experienced for several years. And the feeling is that this is the way to really, because most people have to file tax returns, most businesses file tax returns, this was the easiest way to put it in place. There is a penalty, as Phil mentioned, for non-compliance. It runs around $2,000 an employee, but again, the first 30 employees are not counted. And after that, then they start taxing you for the non-compliance. What's important to understand is many employers offer, particularly to executive or other administrative employees, some sort of cost sharing or premium payment. That no longer works. That will not be considered compliance under this act. Minimum coverage, as I mentioned, is if you're under a government-sponsored plan, which, by the way, is the most insurance that we have in the United States, that's Medicare and Medicaid. Employer-sponsored plan, that would be self-insured, like many of the big industrial employers use, IBM, Xerox, et cetera. And then a market plan based on these health exchanges that Phil was explaining. None of this comes into play until 2014, and one of the reasons for that is because the intervening years between now and then are going to be spent designing these exchanges and figuring out how they work. And we're also now faced with a major switch in the number of Republican governors. We can expect that the number of states to offer exchanges will be less than was contemplated when this bill passed. This is a slide that to me depicts the morass of what this bill really represents. This actually is an electron microscopic photograph of Velcro. You can see how Velcro actually works with the little loops and hooks and so on. But this is what it seems like when you sit down to try and understand what this is all about. And this is what it's probably going to feel like when you try to see how to implement all of this. But the point is that there are many people looking at these issues on your behalf. I would definitely urge you, if you are a small business, to consult with a professional who can help you get through this. And the highlight that I wanted to bring to you is this timeline. This comes from the other handout that I gave you. It's, again, one of the most neutral ones that I could find, and it's very simple to kind of show out exactly how we're thinking this is going to play out. Obviously, the political scene will make that a different picture than we had in mind yesterday. Thank you.
Well, I'm Cynthia Lord. Good morning. And I was challenged with trying to give you all the secrets of how to keep your employees healthy, because that's the other end of this. If to implement all of this, if you have healthier employees, maybe it'll be a little easier. So I will tell you that staying healthy isn't rocket science. It's as easy as ABCs, and that wouldn't be airway, breathing, and circulation. That would be aspirin, blood pressure, and cholesterol. I was fortunate enough last week to be with some students up at UConn for National Primary Care Week, and the speaker was Dr. Paul Grundy, who's IBM's Global Director of Healthcare Transformation, and he shared with us the unhealth of our nation. You know, as a nation that was ranked 4th not too long ago in overall healthcare, we've now flip-flopped with Germany, which was 14th, and Germany spends about 10.6% of their gross income on healthcare annually. You know, it's interesting, he spoke about major corporations now looking to locate in states that have the best health care and wellness for the people of their state at the best cost. So moving out of states where it's costing too much to insure and take care of patients in that state. And large corporations now want more wellness for their buck, more bang for their buck. And he talked about demonstration states like North Carolina, which has figured out how to lower their rates of asthma by 43%. Vermont, which boasts one of the lowest costs per person to keep its residents healthy. If we look at the Commonwealth Fund's state scorecard, which compares Connecticut's performance with that of other states across key indicators of healthcare system performance, by moving towards benchmarks levels of health performance, Connecticut could save lives, improve access and quality of care, and reduce unnecessary spending. As employers, not only do you play an important part in that role in our state's ability to reach its benchmark, but your employees would be healthier. So right now we're ranked overall, but if Connecticut were to improve to the level of the best performing state, which is Colorado right now, over 130,000 more adults in our state would be insured. The dollars we'd save from Medicare readmission would be over $36 million. Over 38,000 more adults would receive eye, foot, and hemoglobin A1C testing to help prevent and delay complications of diabetes. And over 13,000 adults in Connecticut would receive recommended preventive care like vaccines and colon cancer screening, mammograms, etc. So where do you begin? Well, first you have to get rid of your bad habits, bad behaviors, and that would be smoking and tobacco. We know that tobacco is responsible for more than 430,000 deaths each year and is the largest cause of preventable morbidity and mortality in our country, according to the CDC. It's the recognized cause of many cancers, heart disease, stroke, complications of pregnancy, and of course, chronic obstructive pulmonary disease. So work-based incentives and competitions to reduce tobacco use among workers offer rewards to individual workers and to teams as a motivation to participate in a cessation program or effort. So rewards can be provided for participation, for success in achieving a specified behavior change, or for both. And types of rewards that you could offer would be guaranteed financial payments or lottery chances for monetary or other prizes, and a return of self-imposed payroll withholdings. When interventions are combined with these incentives and competitions, they yield the best results. And those things would include client education, smoking cessation groups, self-help cessation materials, telephone cessation support, and workplace smoke-free policies, not just within the building, but in the entire property. That means no smoking anywhere on your property, as well as social support networks. In addition, we need to promote healthy living by eating healthier and having weight control. Nutrition among the U.S. population certainly needs improvement. 63% of the adult population is overweight or obese, with fewer than 25% of Americans eating at least 5 or more servings a day of vegetables and fruits. And we know that healthy eating helps lower our risk of heart disease and certainly lowers our risk of being overweight or obese, and as well as micronutrient deficiencies. And so the key to achieving those goals are about maintaining weight isn't about a short-term dietary change, it's about lifestyle change, about healthy eating, regular activity, and balancing the number of calories consumed with the number of calories used by the body. So what can you do? Well, work with your cafeteria to have healthier food choices. Look at putting healthier food choices in vending machines. And support proven weight loss programs and nutrition counseling and education classes at the workplace. In addition, we have to become more active. Studies have shown that regular physical activity can cut the risk of depression, diabetes, heart disease, and less than half of US adults get the amount of activity, physical activity a day that they need. The CDC recommends, as well as if you look at the 2008 physical activity guideline for Americans, they say we need 2 types of activity each week, and that would be moderate to vigorous aerobic activity as well as muscle strengthening, and they recommend about 2 hours and 30 minutes. That's 150 minutes a week of doing something vigorous as well as muscle strengthening. And the recommendation is that you don't do it all at once, that you can break it up into 10-minute blocks, which makes it a lot easier. So encouraging people to walk at work, at lunch, or at their break time, encouraging lifestyle activity, we call it, which is posting signs to use stairs and park further away, and instead of everyone fighting for the front spot in the parking lot, to park further away. Working with your local gyms to get memberships at reduced discounts. Many of them will work with you now, establishing a gym at your workplace or bringing people in. Here we have people come in and offer classes in Zumba and Pilates and yoga. A topic that most people don't think about, but actually is very important, and it's often overlooked, is hand washing. Many diseases and conditions illness are spread by not washing your hands with soap and clean running water. And if they're not accessible, by using those alcohol-based products that have at least 60% alcohol. You want to make sure that people use the proper technique and are washing for the proper amount of time, which is the 20 seconds, and that's hum. If you can hum in your head the happy birthday song twice, that's about 20 seconds. So what can you do at work? Well, you can post signs on proper hand washing technique in all your washrooms, as well as installing those alcohol, kind of the Purell containers or stands throughout your workplace. And finally, remember, prevention is key in keeping your employees healthy. Diseases that can be prevented by vaccines remain the major cause of illness and death for all people in the United States. The CDC recommends a 3-step approach to protect against the flu. First, take time to get a flu vaccine. Second, take everyday preventive actions to stop the spread of germs, and that would be things like hand washing and staying home when you're sick. One of the new terms that have been coined is presenteeism, and that is the tendency for ill workers, people who are sick, to come to work. We clearly, I know you don't want everybody out with a little cough, but when they come quite ill, they infect everyone else, and then more people are out for longer periods of time. Through your employee health benefit plan, you should support regular flu vaccines yearly, as well as cancer screenings for mammographies for breast cancer, pap smears for cervical cancer, and colonoscopy for colon cancer. So you see, keeping your employees healthy is as easy as ABC, and worksite health promotion and prevention is key. Thank you.
Good morning. I'm Angela Mattie, and while we've heard from our previous speakers that although some of the political soundbites have focused on healthcare reform being improvements in quality, we can see that the majority of the focus of the 2000+ bill is on insurance market reforms or payment alignment reforms. There are, however, some quality provisions in the healthcare reform bill. And today, I'm going to just highlight the major ones, which, and Cindy and I did not speak, but the first thing is what's the new alphabet soup as it pertains to the healthcare quality provisions. I'll go over 2 in particular. 1, ACOs, Accountable Healthcare Organizations, and 2, probably the most controversial, is the CEF, Clinical Effective Research. And then I'll end by just some brief comments on what employers can do in preparing to get ready for these big changes. Accountable healthcare organizations. This is the new fad. And basically, we have yet to really understand what they're going to look like because the regs aren't in place. The first phase of accountable healthcare organizations will pertain to patients in Medicare. However, if you talk to anybody who works on the Hill, it's a matter of time before this model is phased into all insurance programs. There's three principles around accountable healthcare organizations. One is managing the continuum of care. So the impetus and the intent in the legislation is to have primary care, specialty care, and hospitals form consortiums under legal entities to provide care from the primary care episode all the way to the hospitalization. These organizations will be responsible for monitoring, tracking, and reporting clinical outcomes. Is the care they're providing making a difference in terms of the patient? They will also be responsible for keeping costs down. So cost and quality will be tied under one continuum of care for patients. Now, the regs are due out the end of December. We have yet to see whether or not that will occur, with a planned implementation date of 2012 for accountable care organizations. But this is absolutely the new buzzword. There are problems with this, and I assume that my colleague John might talk about some of the antitrust issues that still will be debated. In other words, will these organizations form monopolies at some point? And there's also several issues about what will they look like. So yet, still to come. The other one, and probably the most controversial, and I just had the privilege of being down in DC. This is the new buzzword, comparative effectiveness research. In its purest form, it's what works and what doesn't work in healthcare. However, there's lots of information and lots of debates. The stimulus bill set the foundation for it. As we heard from Phil, there's a panel in place, an advisory board that was just appointed in September that will oversee about $500 million annually for comparative effective research. Now, these have been called by opponents death panels. In other words, will the data be used to make determinations whether or not 95-year-old grandma gets the treatment? How much will cost come into play? They have also been criticized for injecting the government into medical decisions and potentially serving to ration care. If treatment A is not quite as effective as treatment B, does treatment A not get funded? So again, this is the new buzzword, CEF, clinical or comparative effective research. The jury, again, is still out whether or not it will take traction and how these data will be used in terms of funding certain procedures and treatment modalities. There is good news, though, for small employers. And starting in 2011, there will be grants to do things that Cindy just talked about in terms of comprehensive workplace wellness program. So if you're a small employer with no more than 100 employees, you currently do not have a wellness program in place, there are potential to use funds to establish a wellness program. Now, the government realizes that for every dollar a small employer places in wellness programs, the return on investment is $3. Now, right now, this has not been funded. Hopefully, there'll be appropriations for these small grants. Information on this can be found as the Department of Health and Human Services works out an application process on their website, which has yet to be done. So with everything that we've heard, what can you do? Well, I think the first thing is educate yourself. Of the 2,000-page bill, there's about 1,200 places where it's indicated that the secretary shall. So that means that the intent of the bill is there. We don't know at this point how it's going to be operationalized and how it's going to be implemented. So to continue to review websites, regulations, understand the timeline that Lynn handed out, and begin to educate yourself on the ABCs of healthcare. Make use of resources. Speak to your insurance brokers. There's an administration website that it's fairly good to take a look at. That's up there. It's www.healthcare.gov. And the U.S. Chamber of Commerce has created a document highlighting the issues that employers need to be looking at. The other thing is, if you're confused as a business owner, your employees are even more confused. The key is to communicate with them. What do you currently know? What don't you know at this point? And when will you know? And the last thing, this is not quite as illustrative as Lynn's slide, but don't panic. Be prepared, but don't panic. Each of these provisions has a phased-in period. Not everything has to be done tomorrow. So preparation is the key. Try not to panic. You have done this with other laws, FMLA, ADA, etc. This is more complicated, but it has steps and a phase-in period. Thank you.
I think you should panic. I disagree completely. And if you're like the rest of the world right now, you're of one of two minds. One is that we've had the rest of the country. This is the start of something potentially good, or it's the start of something horrific. And so you want to know whether it's going to start. There's actually a legitimate possibility it doesn't start, not just because of politics, but because of the court system. We've talked about the legislative branch, enacting this bit of law. We've talked about the executive branch, has begun promulgating regulations, and next month we'll see even more, but we haven't talked about the judicial branch. And that actually is the biggest barrier right now, potentially, to the implementation of any of this. So I'm going to go through this quickly. I've got 14 seconds, and I can do it. So I'm going to talk about the pending cases. There are lots of them. A little bit about what the arguments are. We have two diametrically opposed cases, the only two so far to go to decision. Very different viewpoints on the legislation and a completely different result. And then I'm going to give you, well, really a non-prediction. So let's talk pending cases. I put it up there so you can't see it because this is what we do as lawyers. We make sure you can't understand it, so you'll pay us to read it to you slowly. There are 20 cases. We now have a change in the gubernatorial landscape, political change. We're going to get more lawsuits. There are 20 lawsuits. There are more than 20 states involved, and you can't really see much of it. I think I have a pointer. Look at this. I'm up there with this reflecting head, and it's really bothering me. Now I can just bounce this off glasses up there. Anyway, a couple of interesting things. You can't see much of this. This is only half of the cases, but you can see this one has 20 states involved. I'll talk about that briefly momentarily. You can see that the defendants change. We sue Sibelius. We sue Geithner because of economic issues. We sue President Obama. This is... I tell my students, we're not talking about life and liberty. We're talking about the American way, lawsuits. We've got lawsuits going on here. All kinds of interesting legal arguments, but one thing you'll see here, and I'll get to those in a moment, is the parties on both sides change. We have citizens suing. We have elected officials suing. We have elected officials going with citizens to file lawsuits so that the landscape with respect to these lawsuits is complex and entertaining because we have varying casts on each side of the versus sign there. So let's take a look at these. This is a summary of the arguments. You can't see this either because you have to pay me my billable hour to read this to you later. I like this very well. But the first one is the Commerce Clause. You can see up here that Article 1, right at the start of the Constitution, gives Congress the power to regulate commerce. We got two, and this is the biggest argument. This is the argument that's going to resolve this thing one way or the other, and it's going to resolve it next month. I'll get to that in a moment. The constitutional argument is this affects commerce. We have an economic condition in our country. We spend way more than any other nation. Way more than any other nation. Our outcomes are worse. There's an economic consideration. The treatment of healthcare crosses state boundaries, so interstate commerce is implemented. The unconstitutional argument is this, and this is the interesting thing. The government makes you do all kinds of stuff, right? You've got to get a Social Security card, you've got to pay taxes, you've got to do all this stuff. This one's different. If the government had decided to create a national healthcare system and make you be part of it, that's one thing. What the government has done here is going to make you buy a product from a private company. Never been done before. So think of this. What if the United States government said you got to buy a car? Or you get penalized. Ooh. You might want to buy a car, but it's different to say you have to buy a car. That's different than saying you need a license to drive your car. So the argument is very, very interesting. The other ones are essentially structure of government. The 10th Amendment to the United States Constitution says the powers not expressly given to the federal government stay with the state. And beyond that, neither of those powers given neither to the federal nor the state governments stay with the individual people. The 10th and the 9th Amendment together. We have a government of limited powers. What happens when the government tries to restructure in a national system? It's really a federalism argument. Can the federal government make states do things? So the first one's an individual argument. Can the federal government make you buy something? The second argument is, can the federal government make the states do things? And the third set of arguments is a free exercise of religion argument. This one is very tenuous, but we'll see it in the next case, the second case. It really goes to abortion rights. The federal government has in place a Hyde Amendment. You can't use any federal funding to fund abortions. This law makes no change whatsoever to that, but there's a black hole. And the black hole are those exchanges. The folks who are between 133% and 400% of the poverty level, right? We're going to kick up Medicaid to 133%, but those folks above that to 400% potentially go into these exchanges. Folks are worried about what happens in those exchanges. Again, federal law hasn't changed. Can't fund abortions. But no one's quite sure how that's going to shape out when the feds work with the states to buy private insurance. Is that going to work out? So, the arguments. The first case that came down, the first decision, well, actually it's the second decision, but anyway, October 14th, is the biggest one. And those are the states as of last night that were involved. I don't know what that's there. I guess New England, Nebraska is bigger than Pennsylvania. I didn't know that. Anyway, typo. But anyway, it's flatter anyway. We got 20 states involved. It's state attorneys general. Again, I think with the change in the landscape last night, we can expect more. Here are the claims. The first claim is a Commerce Clause claim, and the second claim is the 10th Amendment claim. The feds can't step on state rights. That's the interesting one. The Commerce Clause claim is pretty. My time is up. Thank you very much. Just kidding. So here is the ruling. The ruling is, so what happened was the federal government moved to dismiss this lawsuit. The judge, it's Judge Vinson, a Reagan appointee in Florida, let the lawsuit go forward and said a couple of interesting things. The first thing, and I don't have it up here, the first thing he says is, this is a very controversial and potentially troubling bit of legislation. Tip off, right? Then he lets the lawsuit go forward because he says the power to make you buy something from a private company looks like it's outside of the Commerce Clause power. But more important than that, from his perspective, he says making states do something because there's a line somewhere between mere pressure and impermissible coercion. His theory is this coerces states. He's letting the lawsuit go forward. We're going to have a hearing December 16th on motions for summary judgment. That just means there's no argument about what's going on, no factual argument. We don't need a trial. We don't need witnesses to stand up and say what's in this. It's a pure legal argument. It's going to be brief. He's going to decide it. We'll have a decision by the end of December, or at least by the first of the year. Judges take these under advisement. We call it under concealment, right, to make a decision. By the first of the year, we're going to have a thumbs up or a thumbs down on this case in a federal court, and it's going to go up to the Court of Appeals. All bets are this judge, if you read this decision, it's 65 pages. I urge you to read it. Let me know. I'll send it to you. This judge is going to rule thumbs down. I would bet that right now. Okay, what about the other one? Well, we got one pending in Michigan. This is all fun. It's all politics. Hopefully it's not all politics, but there is a political component. Now we have a Clinton appointee. He takes a look at this lawsuit, and he says, first, to summarize the bill, you know, this is a very interesting problem we have in our country because of the rising healthcare costs. And this looks like it's roughly a rational, you might not agree with it, but a rational approach to this. So we get a completely different result. The plaintiffs, the parties seeking to challenge the lawsuit, wanted to hold off the implementation of the lawsuit. The judge denied it. It's going to go to trial. And what we have is this. He says, in my little light, I ran out of batteries? Oh, it's bad aim. Okay. He says that this, if we have this commerce power argument, if we have an integral part of a bigger regulatory scheme, this little tiny bit of the mandate, it's an integral part of a bigger regulatory scheme to control something that affects interstate commerce and has real economic impact. It's legitimate. It's not a big deal. It's just either you buy this or you pay a tax. That's all it is. Very different conception from what our Florida judge had. And then he says this minimum coverage provision is really essential. If you don't have that, you can't control costs. And we all know this argument, right? We know that folks who don't have health insurance, we may be cold-hearted, but we don't let them die on the sidewalks very often, right? We give them treatment. They go into emergency rooms. It costs a lot more. It raises our healthcare costs. There's not an economist on the planet who will tell you that costs will not decrease if we get everybody into insurance. It's going to work if we get everybody in. The question is whether we can legally do that. So what happens? This is on appeal. This one's going up, of whether this lawsuit can go forward. So by the end of the year, we're going to have two decisions. One's going to be thumbs up. One's likely to be thumbs down. They're going to work their way to the Supreme Court. If you look at the timeline, Supreme Court usually takes a couple years, but these are not factually contentious cases. We don't need big trials. We will probably have the Supreme Court decision on this before the next election, before the presidential election, of whether this lawsuit stands or not. Okay. So what's my prediction? I don't have a prediction. I will tell you this. Historically, the Supreme Court has been very deferential to what Congress wants with respect to the Commerce Clause. If there's some argument that actually affects interstate commerce, we can enforce the Civil Rights Act. Right, if you get your catch-up through the interstate commerce, we can't discriminate against anybody who comes in your door. We've been very, very liberal. We've deferred to Congress historically. The question is whether the courts will defer to Congress this time. We have a very different Supreme Court than we had back in those early Commerce Clause decisions. And a really intriguing notion. If we look at the face of the law, our Michigan judge did that. It says this is purely a tax. It's not a penalty. It's just a tax. You just pay a tax like any other tax if you don't buy insurance. If you do what your Florida judge did and look at the legislative history, the administration forgot to coach the members of Congress. And they called that tax a penalty in the legislative history. So if the court will look at the legislative history, now we have the government penalizing you for refusing to buy something from a private company. Or, if we look at the face of it, you get taxed if you don't buy this thing. Very different conceptions, very different outcome, and I think it's impossible to predict what will happen. Thanks.
Well, good. I'd like to thank everyone on our panel for contributing today. We would like to open the floor up to some questions you may have, and we do have some time for questions. So, got everything you need to know. We tried to give a broad range of inputs from both the employer side. Even though you may be employers, you're also employees, so we try to bring some of that in as well. So, any questions, please?
If I understand this right, if, as an employer, I offer employees an insurance plan and they choose not to accept it, they will get penalized. The employer will not, as long as it's under 30 employees that don't take coverage, correct?
If you look on this handout on page 5, there's a nice table that sums up what gets penalized and what doesn't. So you're offering coverage and they don't take it.
If it's under 30.
As long as it's under 30 and the part-time issue doesn't come into play, I don't think there's an.
That's right.
That's that's when the individual. Gets the penalty.
Right. No penalty in that case.
The idea is if you're offering a legitimate plan, you're always going to have one or two people who, don't want to play ball like everybody else. If you have 50 employees out of 70 who don't accept it, there's something wrong with the plan. So there's an exception for those hardball guys who just don't want to participate.
Yeah, there's a percentage of the population that wants to either self-insure themselves and don't even want to be part of this no matter what we do. So that's another piece of this. So, any other questions?
And participation, that's 50%, paying 50% of the premium for the employer. Is that correct?
The cost sharing is what's at issue, and you can do what you do now, but if you give somebody money to go buy their own insurance policy, that's what's not going to be called compliance. So for instance, a lot of executives have the freedom, they just get reimbursed for their own coverage somewhere else. That's no longer permissible.
And how about in a sentence or two about I'm a physician with 12 employees. What's it going to mean for me?
12 employees?
Yeah.
You're exempt.
So the only thing that's going to be for me, I get a tax credit if I offer.
The tax issue I'm not as familiar with, but my bet is that if these exchanges, the whole notion of these exchanges is that it makes a competitive marketplace. And it might actually give you better options, even though technically you're not required to go in and cover your employees.
We offer over 50%, and so we're going to get a tax credit, as I understand, starting this year.
That's correct.
Yeah.
You get the tax credit. The thing is, there are two exchanges. One is for folks, individuals who can't afford insurance and don't receive it. The other is for small businesses, under 50 employees. And so you would have the opportunity to go into this exchange, which theoretically has a lot more market power, and hopefully get a cheaper rate.
Down the road if they exist.
Yeah.
If they exist, right. Exactly.
Right, we haven't talked about Sustanet yet, but that is going to expand, I think in 2015, to include any small business with any number of employees can join into that as well, the state-run program. So.
And the tax credit is retroactive too.
Right. To 2010.
Right.
Correct.
I'm imagining a whole new industry coming up. You said consult with authorities and know about
Yes.
Who will they be? How will they distinguish?
Oh, this is a full employment act for lawyers. I think it's a great idea.
Definitely lawyers, the insurance industry, I think your accountants, and I think, I remember back when the big tax laws changed in the 70s, financial advisors became an industry. I think that there now will be some class of people that is not quite a lawyer, not quite an insurance person, but who's very well versed with what's the best way to go here.
And to plug one of my
Chamber
colleagues.
is really keeping an eye on all of this too. I will say your professional organizations are the ones who will no doubt offer you advice.
Yeah, and may I just say something, having worked on Capitol Hill, and you need to take advantage of your advocacy organizations.
Yeah.
They're there every day, closely monitoring this, and not only do they understand what's printed, they understand the whispers in the hall. So first thing I would also urge is get involved in your advocacy organizations. Just because we're sitting in an auditorium in Connecticut does not mean we can't have an influence on policy. And remember, the law's in place. We don't even know if the law's going to stay. But the decisions about how it's going to be implemented have yet to be determined. So don't underestimate your voice in your advocacy organizations. The U.S. Chamber is a wonderful resource. They have a fair amount of power right now on Capitol Hill. If you belong to any HR benefits organizations, pay attention to their websites, pay attention to their materials, pay attention to their talking points. The National Governors Association is another great place to start. There's a Small Business Association. So I can't emphasize enough to make use of those resources. A lot of the materials are free. And don't underestimate your own power as a small business owner to make a difference if you get involved with your advocacy organization, to have some say on how these things are going to be implemented and how the regs are going to turn out.
And I would just even add to that, just our local, the New Haven Chamber of Commerce has, I believe, over 2,000 small businesses, and there's power in that alone. And one of the things I will tell you from a consultancy standpoint, you know, the so-called experts on this, you know, finding one person who truly understands the span of that, it's going to be very difficult. I do think it often will take a number of people, a lawyer, an accountant, a tax, you know, I mean, think of the, you know, for the ramifications on the business. So it'll be a challenge. Yeah.
But I think from a starting point, sit down and really understand what you currently offer. That's the first thing. And then closely monitor how things are going to move. And don't forget that the anxiety and the ambiguity that you're feeling as a small business owner, multiply that times what your employees are feeling too. So continue to communicate with your employees as you go ahead.
My field is stress management.
Oh,
Great.
Oh, she's one of the 10.
So-
you're going to be popular.
There you go.
Good.
In the back?
Yes, for small business owners that are particularly concerned about issues here in Connecticut, there's a group of business owners, which I'm affiliated with, called Small Business for Healthy Connecticut. There's a website with some very helpful information on it called sbhct.org. If anyone wants to know more information about that, I have information about that. Please feel free to see me after.
What's the website again?
sbhct.org.
In terms of wellness and prevention, what do you see in the future for the implementation of non-invasive preventative therapies such as chiropractic and other non-traditional therapies?
I think that's where that, what Angela was talking about, the comparative effectiveness research, I think that's where a lot of that is going to be determined. It also will come into play with how the exchanges, I think, are set up, because there are companies now that cover a lot of so-called alternative modalities, and you know, many people end up already spending quite a bit of money. There's more money spent there than I think there is in the insurance market. Right. So I think there's a good chance for that.
One of the provisions is that the Secretary of HHS is tasked with defining what constitutes a minimal acceptable plan, sort of a baseline plan, and that includes what services do you include in the plan. So it'll be people trying to influence the Secretary to get their plan, their organization included, and so it'll be a somewhat political and influence question as much as anything else.
But the interesting thing about comparative effective research is that this may be the first step toward rationing care. So as much as the pure people at Institute of Medicine are saying this is just to see what works and what doesn't work in healthcare, I would venture to say that it is the first step in saying what works, what doesn't work, but how do we allocate our healthcare dollars to get the most bang at the end. So we haven't heard the end of clinical or comparative effectiveness research.
And that's what I alluded to, where large corporations aren't waiting for the feds. They're taking that in their hands already and looking at states saying, I'm going to relocate out of Connecticut because it's costing too much. It's costing me $177,000 per employee to keep them healthy. If I move to Vermont, it's $17,000. That's a big difference. So they're actually looking, and that's what IBM goes around evaluating, and they're looking at states that are more cost-effective to keep their employees healthy.
I know it's a tough question to ask, but what are we looking in terms of a timeline of comparative effective research to start basically giving us information back? Is it like 5, 10, 100 years?
No, that's a great question, and that's one of the criticisms. In terms of a timeline, things are already rocking and rolling. The panel was put in place September 23rd of this year. The dean of the medical school at UCLA is the current chairman of the panel. It's a 19-member appointed panel. Matter of fact, Arlen Krumholtz from New Haven is actually on that, who's done a lot of the work in MIs and cardiology. One of the criticisms around this is to really do an effective clinical trial, it takes time. And are we going to rush these data through because we want to then begin to apply them to outcomes, cost measures? So it's an excellent question. Health Affairs October issue was devoted to this whole issue. If you want to know more, there's actually PowerPoint slides and videos. It's not going to go away. It's a highly political issue, highly sensitive issue, but you know, to quote Neil Armstrong, it's one small step for man, one giant leap for mankind. I think the domino effect has begun, and we are beginning to say, you know, what's the cost and the quality connection, and what's the data to support those decisions?
I would also add there's the research also complicates the issue. So for instance, in people with lower back pain, I can find a paper that says surgery is the best outcome, physical therapy is the best outcome, chiropractic is the best outcome. I can also find a paper 6 months later that doing nothing is the best,
Exactly.
is equally as effective.
Right.
Right, so this gets complicated. You know, these research papers come out and you can find, you know, it's not always clear cut.
Well, another example is there are already federal panels that establish guidelines that Medicare that guide Medicare's decisions to pay or not pay for things. That's existed for a long time. But there's a political issue with those decisions, and the most recent brouhaha was when they changed the age limits for mammography, for screening mammography. There was a huge outcry. If you looked at the science that they based their decisions on, it's pretty good. It wasn't an unreasonable thing, but the idea that all of a sudden we're going to restrict how much we're doing, they had to back off from that. Sure. So each one of these decisions is going to have blowback, particularly the more unpopular ones, even if they make perfect sense.
Question back here? Anybody? No, we're good. In the back.
No one spoke to the grandfathering that is part of this whole healthcare reform. Are there any highlights that you might give us on that?
Well, like everything else, it is unknown, and there's a lot of controversy in exactly what will be grandfathered. But I think a starting place would be to see if we can get to this definition of what minimal essential coverage is. I think that's going to be the key as to whether or not you even have a chance of grandfathering in. All of this really comes down to how do you define something and what is it. If these exchanges don't get up and running, one thing I will say is, Ed mentioned Sustanet, a lot of states are moving towards some state-run mechanism, and all of a sudden, because of the fact that maybe the exchanges are not going to happen as rapidly as we thought, it's going to make the state plans even more important. And there's a lot of people in Connecticut, a lot of official panels looking to inform Sustanet as to whether alternative modalities or whatever, lots of different pieces. Do we have enough primary care providers? Do we have enough access? Even if we have enough providers, are they taking new patients, et cetera? So it would be, again, through your advocacy groups, really monitoring what's happening in your state. Because Connecticut's very well poised to move ahead. Sustanet has been here since 2008, under study, and rapidly moving forward to form, and then health reform passed, and everybody said, well, let's just kind of wait and see what happens. I think now there'll be a forward momentum at the state level.
I think the correct term is grandparenting.
Oh, yeah.
That's right.
Good point.
There you go. Any other final questions? Well, we'll be around for a few minutes if you want to come up and talk to us individually. But I thank you all for coming, and I want to thank the panel. So.